Good morning, everyone. This is Neil Davis, and welcome to our weekly pediatric-focused COVID WebExes. Just as a reminder, with the wonderful sounds we're hearing in the background, but a reminder to mute yourself if you are not. And also, as we get through the presentation, we will take questions via the chat function. The little voice cloud down at the bottom of your screen gets you into the chat function. Let's go ahead and get started. We are really lucky today to have Lisa Giles and Brooks Keeshin with us. Lisa is an associate professor of pediatrics and psychiatry at the University of Utah. And she did her training at the University of Utah and Cincinnati Children's, so Primary Children's and Cincinnati Children's. And she is the director of Pediatric Behavioral Health Service Line for Intermountain Children's Health and Primary Children's. And then Brooks Keeshin also did his training, I believe, Cincinnati Children's and then University of Utah Primary Children's. And he is a child abuse pediatrician and child psychiatrist. And he also directs the integrated post-trauma services at Primary Children's, which is a Category 2 center of the National Child Traumatic Stress Network. And I just might add, both are wonderful colleagues to work with, and it is a privilege to have both of you. And with that, Lisa, I will pass this to you and remind everyone to send your questions along the way via the chat function. Lisa, you're still on mute. Let's get you off mute here. You are still on mute, Lisa.
Try *6.
Bridget, you might be able to unmute her also by clicking on the right side of her name. There we go.
Sorry, if I stopped sharing, I could unmute myself. So
okay.
Now let me get back and share my screen. and we will get started. Thank you for having us. Brooks and I are both excited to be talking today. And really, what do we know about pediatric mental health and COVID? The answer is still not a lot. We are learning as we go. But we want today to, quickly be able to kind of talk about what we do and do not know about that relationship, some suggestions for screening, and then simple interventions that we can start doing that should make a difference. So these I just pulled from articles that have come out in the past week or so. Many people saw the Washington Post on Monday, talked about the suspected impact of the coronavirus on mental health. This is, in adults, but just through surveys, most people are thinking, yep, this is affecting me. No surprise there. In pediatric literature is still pretty limited, but we are starting to get a handful of reports from China and from Europe that are looking at the effects of the coronavirus on mental health. And so this table 1 is pulled from a JAMA article of last week that basically showed the numbers circled in red are basically showing about a 1 in 5 rate of kids that screened significant for depression and anxiety after being isolated for 4 weeks at their house because of the virus in Wuhan, China. So, again, I'm sure there'll be plenty to learn. It's interesting. We've seen at Primary Children's, we've seen our number of crisis evaluations in the emergency room drop, as most emergency room visits have, and yet inpatient visits have still, inpatient units, psychiatric, have still stayed full, and there's still certainly a sense everyone has of plenty of ongoing pathology, and certainly a suspicion that more will come by fall when kids are returning to school. So really, I mean, I like to think about it in kind of these three chunks. Certainly, as we know, there are plenty of pre-COVID mental health concerns that we all deal with and struggle with on an ongoing daily basis, right? Depending on, the studies you look at, overall prevalence of depression, anxiety in youth is probably somewhere near 20%. And we probably we're not doing a fantastic job of dealing with all mental health needs even before COVID hit. And then we've got all those COVID stressors, and we'll talk about a few of what those are. And in the context of these kids are not coming to see their pediatricians. A lot of behavioral health centers closed, at least initially for a little time. Schools are closed, so school counseling and other kind of external monitoring. So all of those can certainly set us up for challenges. This slide's pretty self-explanatory. People can read it, but obviously there's a lot of possible stressors that are occurring to kids at this time. Some of the most significant just being that lack of routine and lack of structure that kids seem to do so well with just the daily kind of school routine and that, let alone kind of the economic hardships and that, which we know cause tons of stress on parents and adults, and then kids tend to follow that stress several months after the fact. So, what's unknown? Obviously, we don't know what the coming months are going to bring. These are the UDOH case number accounts, and we don't know what May's going to bring, and we don't know what this exact sequela for pediatric mental health is going to be. But we do know certainly that youth and families that already have existing challenges are probably at greater risk for more difficulties. That seems to be known across the board. Kids that had premorbid stuff before they had cancer have more challenges and all of these sorts of things. But we also know kids are resilient. And so for the most part, kids are going to do okay because they are so resilient. But that distress response can vary. But we know a lot about how to help kids in times of needs and how to help them when they are stressed. And so with that, I'm going to turn the microphone, maybe, over to Brooks, so he can start talking about, so what do we do with that?
So thank you, Lisa. And so let's start the conversation about in terms of how do we screen for these kids, or how do we clarify the concerns that parents might be having. So what I'd like to go through over the next few slides in the next few minutes is reviewing some of the information that we have on best practice for screening. I'll be showing you something from the Pediatric Traumatic Stress Care Process Model, along with screenings for depression, anxiety, and behavior concerns, and talking a little bit about suicide screening and response. And I think what I hope that we can kind of take away from these next few minutes is this idea of how do we do this in the context of these changes that we're experiencing with regards to COVID and the secondary adversities that are happening with result of COVID. And how do we take a lens that really kind of starts that conversation off in terms of talking about the context and the experience that the families are having, rather than moving straight to symptoms and diagnosis. Next slide. So this is a general suggestion for how do we kind of, if we're not going to use specific screenings, but we just want to be systematically engaging our families, what are three critical pieces that we could be doing with every single family that comes into our clinic? If we're going to talk about stressors, we really do need to kind of set the frame for this. So if I'm going to say, I want to know how the family's doing with regards to COVID and all the changes, it's not as helpful to say, so how are things going? But really to frame it with, so, I've been seeing a lot of families who've had different reactions to COVID, or, something nicer and more pertinent to your families than that. But set that context and say, like, this is something that's impacting families. And so let's ask a question about experiences. What has your child experienced, or what has your family experienced? It's much easier to engage the conversation around experiences and then move towards impact than just start fresh with the impact or the symptom piece. The other benefit of doing it this way is that a lot of families who are struggling with behavioral or emotional challenges with kids, they'll often focus on the symptoms and not think about the context, the environment, the other situational pieces that may be driving those symptoms. If we ask questions this way, talking about experiences first and then identifying symptoms, we're starting to lay that groundwork of saying, hey, maybe these things are connected, and maybe there are ways that we can address some of the behaviors or symptoms of concern that are contextual, that are around the environment, that are around our daily routines and activities, rather than kind of being hyper-focused on the symptoms and the parents wanting to say, well, just make this symptom better. Just fix this behavior my kid is doing. Next slide. One of the options for screening is certainly trauma screening. And this can either be done universally or can be done as kind of a secondary screen if parents have concerns about other issues. What trauma screening does is it parallels the idea of kind of setting the stage. Are there scary, traumatic experiences that my child has had? Then it asks validated, systematic symptom questions to identify, does that child have traumatic stress? Lastly, within this model, that's available for free on the Intermountain external website. There's also the PHQ-9 question 9 to screen for suicidality in these kids. When this is done well, and thank you, Lisa, for the highlight there. When this is done well, this is really the start of a conversation. We're talking about life experiences and we're letting the family know that we are a safe place to engage in this. And we can start to talk about, well, this is normal that kids will experience some of these reactions or some of these symptoms. It also allows us to start to identify what are the trauma symptoms that are most pertinent to this child and maybe identify those first and respond to those first. So like the first two questions in the screen are focus on sleep, which is something that we commonly see in kids who are experiencing COVID and earthquakes and everything else that's going on. But also importantly, thinking about the safety of the child, and whether or not there's any suicide concerns. If we do have suicide concerns, and this is the next slide, Lisa. The PHQ-9 question 9 is really a good sensitive question to identify kids who are at risk for suicide, but it's not a very specific question. So in all of these things, and you're going to hear me say this several times, we need to then clarify among kids who screen positive for suicidality, are they low risk for suicidality, or is there a higher risk that warrants a more urgent or crisis evaluation? The Columbia is a really nice way to do this because you can basically ask generally just 3 questions, questions 1, 2, and 6. If question 2 is positive, you ask questions 3, 4, and 5. But it really helps you tease out which are the kids who are passively suicidal, where really kind of awareness by the parents and some education, maybe the Safe UT app can all be really good definitive steps, versus those kids who actually have active intents or plans for which really a crisis evaluation would be warranted. Next slide. So I'm not going to spend a lot of time on the PHQA because I think a lot of you are already very immersed and engaged in this. But I want to just say a couple of main caveats. One is that the PHQA is sensitive, but again, not specific. So in the context of COVID, if we're seeing concerns of depression, if we're seeing, oh, I'm worried about the depressive disorder that I think my child has, important to still go back and think about the context. What are the social issues that are going on with this family? What are the other things that might be driving it? Do we need to screen for trauma, which can oftentimes mimic depressive symptoms, but if we don't ask specifically about traumatic stress, we might miss it. And of course, the PHQ-9, the PHQA is really helpful in that it does have that suicide screening question, and we need to respond appropriately, ideally reflexing to the Columbia. Next slide. For anxiety, it's important to know what we are screening for versus what we're not screening for. So a lot of folks like to use the GAD-7 because it's short. And just to remind everyone that generalized anxiety is prevalent in pediatrics, but also happens later. So if you're doing the PHQ-7, you might be missing kids who are having anxiety symptoms that are more in the separation or social anxiety domains. But of course, things like the SCARED, which is 41 questions, which covers all those different domains, is pretty prohibitive to do. Also, very important to remember, if you have kids who are anxious, they are at risk for suicidality. So we need to be going back and making sure that we are screening for suicidality if kids are positive from an anxiety standpoint. Next slide. And then my last screening questionnaire, kind of just hearkening to this idea of kind of ADHD or behavioral issues. And just a couple of things I want to quickly say about this. Really, I don't think there's a huge need to screen for behaviors in kids because I think parents are going to tell us if there's behaviors going on. But I think if they want us to do an evaluation of behaviors, given the context of COVID, given everything that's going on, we really need to be thinking broadly. Are these behaviors that are indicative of a primary behavior disorder, or is this trauma and we need to be screening for traumatic stress? Is this other types of secondary behavioral issues? Or in a lot of ways, that first line there, is this really reflective of parental capacity decreasing because of parental distress? And really, there's actually been no change in the behaviors of the child. And lastly, and I just want to repeat this over and over again, in these behavioral screens, there are no suicide screens embedded within them. So if you see behavioral issues in these kids, we really do also need to make sure that we are screening for suicide in those older kids and teens as well. Lisa.
All right. Well, thank you. So then, okay, parents, we're checking in, parents are reporting concerns, or we're screening and seeing concerns. Well, so then what next? What do we do about that? I think for me, the way I like to frame things is in kind of simple, like let's first just triage to level of impairment, right? And I think even at these times, it's less about what is the exact diagnosis and exactly what's going on, and just how impairing are these symptoms, whether we're talking traumatic stress, depression, anxiety, behavioral difficulties. How impairing are the symptoms? Is it, hey, it's there, but we're still otherwise functioning okay? Or wow, no, this is really interfering. We're not able to be completing any of the online schooling we're supposed to be doing. We're not able to be functioning appropriately as a family. How impairing are these? And then based on those, there are interventions that we can do, and we can start even just on the primary care office setting. So I start with severe impairment because in some ways these are kind of the most straightforward, know what to do. These are kids where, wow, this is really impacting, things are really problematic. We got to do a little more figuring out of what's going on, right? I need to have you come back. We need to be doing a little more of an assessment, getting some sense, at least diagnostically, what category am I putting you into? And then chances are I'm going to be referring for evidence-based therapy, right? Either cognitive behavioral therapy, parent-child interaction therapy, depending on what the issues are exactly, I'm going to be referring for evidence-based treatment. I may be considering medications if it's indicated. Again, trauma, it's not going to be indicated, but severe depression, it is going to be indicated, right? And I may even need to be referring to psychiatry or kind of, phoning a friend and getting a psychiatry consult. On the other end of the spectrum is the more mild impairment, right? So these are, hey, there's starting to be some concerns. Maybe I'm having some sleep difficulties. Maybe there's some mild depression symptoms that are showing up on my PHQA. Maybe there's some mild trauma symptoms. And so what do I do in these situations? Well, there's actually a lot that just as pediatricians can be done. We'll talk a little bit more about this idea of how do we encourage supportive parenting? What's the role that parenting can play in this and the difference it can make? Just the role for education, for resources, what's going to happen next? How are we going to follow up on this? And then there's very brief targeted interventions that in and of themselves can make a significant difference. And so again, if sleep is the main issue, and that's kind of what's identified as one of these impairments, well, let's spend a little time talking sleep hygiene. And let's talk about some mindfulness and maybe referral to an app or something that's going to help the ability to kind of relax and go to sleep. If it's depressive symptoms and just kind of this hopelessness and lethargy, let's talk behavioral activation, right? Let's make a goal of just getting outside once a day. And so there's often these just brief targeted interventions that have been shown. Again, we've got good evidence that these can play a significant role in improving mild symptoms of depression, anxiety, traumatic stress, et cetera, et cetera. We talk about supportive parenting. These are kind of some of the specifics that we look at, but just that importance of, spending one-on-one time with kids. And then when consequences are needed, how do we do it? Again, very simple interventions that can make a huge difference. The resources. So we talk about the importance of education and resources. And I don't know about everyone else, but I get overwhelmed at times because there are so many COVID-related resources out there. It's hard to know. So at the end of the slide, we'll have a resource page, but these are some of my kind of 3 overall favorite sites. One is a Parenting COVID website that just has fantastic links to all sorts of different kind of parenting issues around COVID. The other is the National Traumatic Stress Network. That's got really good things. And the other is the American Academy of Child and Adolescent Psychiatry and their COVID website. So some great resources for families out there. Again, talked about kind of these brief targeted interventions that can be helpful when we're talking more behavioral acting out. It's often parenting strategies. And again, just helping parents feel encouraged to do kind of one thing differently this week that can make a difference in their kid's life. When it's more moderate impairment is then kind of that in between, right? So we're going to try to be doing all the same things we will with mild impairment, providing education, providing support. We're probably going to need to be referring to some evidence-based therapy as well, whether that's with a therapist in the office or an external referral. But in the meantime, those brief targeted interventions give families something to do while they're waiting to get into therapy. And occasionally medications may be needed too after we try therapy and, put that therapy first. So again, really quick overview of all the different kind of interventions, but I think kind of having that triaged approach and then knowing kind of what are some of those steps that we can take can be really helpful. And so we end with this resource slide of just, again, those are kind of the three, it starts with kind of the three websites that just have all sorts of good, coronavirus, mental health, parenting resources that can be hugely helpful for families. And then I include the number of our pediatric behavioral health, what we call our assessment, referral, and consultation service, or ARCS for short, because that's a mouthful, used to be known as our intake office. But this is a really valuable number to have. This is fantastic to be when you need to get referrals for therapy, psychiatry, other kind of external mental health support. Again, it's run through our primary children's behavioral health line, but they're fantastic with both Intermountain resources and non-Intermountain resources. We use them all the time for the kids that, present to the emergency room from primary children's that are coming from all over different geographic areas and all different insurance profiles to help get set up with services. When we need specific trauma-focused therapy resources, Safe and Healthy Families is a great number. And obviously the folks from ARCS can direct to Safe and Healthy Families when needed as well. And then just to remind everyone of the availability, Utah now has a psychiatry consultation access line that's available 5 days a week in the afternoon. And you can call or you can actually submit consults online as well. That can also be a helpful referral. And so with that, I will now pause so that we have time for questions and discussion.
Great. Thank you, Lisa. Thank you, Brooks. We did have a question come in from Toby Cox. And as a parent, Toby, this is a question that I've had as well. Is anyone in your field having discussions with Utah's Department of Education to let high schoolers across the state have the option of taking their classes pass-fail this semester? There's so many factors out of teens' control which are being reflected in worsened grades, and this is causing many kids' anxiety to skyrocket. Any interactions with the school system?
Yeah, so fantastic question. And I think, so we do have broader relationships certainly going on. Both Brooks and I are part of a pediatric kind of suicide group that involves a lot of people from the education system and from the state. I know there are school districts that have done that. So I know Salt Lake School District in particular has done that and made the option for pass-fail courses. But I think that's a really good point. It's interesting. We actually see a lot of kids that have decreased anxiety now that they're out of school. And then a lot of kids with that increased anxiety in school. And then of course the disappointment, for seniors that this is the way they're finishing out their high school and stuff. So it's an ongoing conversation for sure.
Yeah, great question. And I see that Dustin Wise chimed in here that Alpine District has done this. I think Jordan District has done this. I think the way the state of Utah school board tends to work is it's very much, it seems like the authority and the action is more with the local districts. And so our role as pediatricians may be to reach out and ask these kinds of questions.
And just to say one other thing, because I think system resolution of this is really the right way to go, but also remembering from a contextual standpoint, from our role as pediatricians, we have the ability to write letters on behalf of children and families who are struggling to schools if we identify that current stresses are making it prohibitive for them to do their work. And those individual acts clearly would not be sufficient for the whole system. However, if there are enough of those, some of those kinds of actions could also prompt system-wide changes as well. So kind of going back to what do we normally do when a child is struggling and needs some type of exception or needs some type of accommodation within the school system. And providing that same support could actually also result in system change, either at the local or the broader level.
So Toby, thank you for raising that. I think we actually have a meeting coming up with the state school board within the next couple of weeks, and that's something that we can think through with them as well. So thank you. Those who have questions, again, please use the chat function. I have a question while we're waiting for others to come in here. One of the challenges we're having now, Brooks and Lisa, is being able to access these kids that we're concerned about. And so we're reaching out based on registries and, trying to connect with families, but it's difficult to do these kind of screenings effectively over the phone. We usually have relied on questionnaires that people fill out in the waiting rooms. And the technology to be able to do that, to get a questionnaire filled out from home, isn't always available. Do you have any thoughts about how to reach out to this population, even some scripting that we use as we reach out to these folks?
So one thing, I'll just jump in real quickly to say that we actually, in partnership with Intermountain, developed a brief intervention for traumatic stress, which actually is a script to be delivered over the phone or over a telehealth that can basically kind of access those key points that I mentioned in the first slide of what is the child experience, what's going on, what have you been seeing in terms of how that's impacting, and then leads to kind of a systematic way to help start to triage and maybe even offer some initial guidance. So you get the benefit of both kind of screening and triaging those kids while also offering something that they can be doing right now as we kind of think about what the right next step might be. And so if that's something that would be helpful, happy to share that with anybody who would want to use a nurse manager or a case manager in their clinic to be doing some of that with their families.
Yeah, so I guess reach out to Brooks to take advantage of that opportunity. And maybe, Brooks, we can connect some of that information to the presentation that we post online. Lisa, do you have any thoughts on that?
So, I mean, I think I really like what you said about registries. And I know, not everyone's at a place where we kind of have clear registries, but this is kind of a great example of where kind of having a patient registry becomes so valuable is because, again, we suspect, we don't know for sure, but we suspect families and kids that are most vulnerable are those that were most vulnerable before COVID, right? And so you already have some sense of who these families are. And so reaching out to them, I think, is really valuable. And again, we do the best we can with kind of scripts or trying to do a PHQ over the phone or, when we have capabilities through the EMR that it can be patient facing and they can fill it out on the computer. But trying to do those things to reach out and just check in with these families to get a sense of, okay, where are things at? What do we need to be doing?
Okay, wonderful. I do have one other question. I think you talked a little bit about sort of the contextual factors here. I am concerned a little that in the wake of this, we will have an increase in behavioral health needs and that we may be prescribing more SSRIs than we should be, as potentially these types of stresses are best handled by therapy. I don't know if my hunch is in line or not. I'm just curious what your thoughts are.
Yeah. So again, I would agree. I think we all kind of have this sense that we suspect that certainly mental health needs globally are going to increase. We've got examples from, different times of economic challenges that, again, what you tend to see is this trend of first kind of a spike in adult mental health needs, and then it's followed a month or two later by kind of spike in pediatric mental health needs. And so I would suspect as this draws on and as there's additional, economic ramifications that, kids will follow. And I worry about, again, a lot of kids do really, that anxiety decreases when they're not in school and stress, but the longer they're out of school and then having to return, the increased stress that will be. And so I do anticipate we're going to see a lot of that uptake. And so to your second point, Neil, I think it is really important to remember that, again, anytime we're talking about almost any of these diagnoses, whether it's anxiety, depression, certainly trauma, related or behavioral issues, our first line treatment for everything pediatric across the board is therapeutic interventions, and really medications become second or third line. And I recognize sometimes we get desperate and so we throw on meds to be doing something, but really, these kids don't need medications for the most part. They need therapeutic interventions, and they need supportive parenting, and they need these other interventions. And I think as we do a better job of being able to connect to those services, because I know that can be a huge challenge, but I know as we do a better job connecting to those services, then hopefully we can be getting kids kind of first line treatment before we jump to second line treatments.
Perfect. Well, we are at time. So Lisa and Brooks, thank you so much. As a reminder to the group, this presentation will be posted online at the website. We will add in some of the resources that Brooks mentioned. I also want to mention that following this meeting, the Utah chapter of the American Academy of Pediatrics is having a chapter chat. And we are able to do that just on this WebEx. So those who wish to stay on and join in with the Utah chapter chat are welcome to do so. For the others, we appreciate you joining and hope you have a wonderful day. And from here, then, I am going to pass off to Elisa Stoddard or Jennifer Brinton from the Utah chapter of the AAP to begin the chapter chat. So thank you to everyone for listening. Thank you again to Brooks and Lisa. And have a wonderful day.